We'll get started here. My name's Choi, one of the spine fellows. We'll be talking about biomechanics, metallurgy, and implants today. Just going through these material properties and how they impact spine surgery and integrating some basic science in terms of fusion and arthroplasty. So this is the outline for our talks today, or our talk today, biomechanics, material sciences, and then break it down into two major sections with fusions, including rods, screws, cages, and talking about surface coatings. Then briefly look at arthroplasty, cervical and lumbar. So to start, one of the foundational concepts that we'll revisit throughout is Young's modulus, or the stiffness of a material. And this graph illustrates where different biomaterials fall. Cortical and cancellous bone are at the low end onto the left of the graph. Titanium and PEEK are closer to bone, which improves the compatibility and reduces stress shielding. Stainless steel and cobalt chrome are much stiffer. They're better for rigidity, but may cause mismatch and cause complications over time. Understanding where each of these materials are and how they fall relative to cortical bone, a cancellous bone, could predict how well they will interact biomechanically. Again, this is a graph going into some more details, mechanical properties of these different metal alloys as well as bone. So in terms of fusion, there have been a variety of historical implants to aid in bony healing and arthrodesis. And our primary goal of the instrumentation is to provide a essentially temporary mechanical stabilization in order for the osseous fusion to happen. And then recently, there's improved understanding of the effects of these mechanical properties and on medium and long-term patient outcomes. And then leading to further improvements in this design and mechanical. And our secondary goals stabilize, protect neural elements, indirect decompression, as well as avoiding complications. This is an example of an early rod, their Harrington system. It was made out of stainless steel. These early rods offered rigidity, but were limited in malleability and failed to mimic the natural spine biomechanics. And over time, the field evolved to titanium and cobalt chrome, depending on the balance of stiffness versus flexibility that we would need per case basis. Titanium is widely favored, with cobalt chrome used where you need further rigidity and correcting deformities. PEEK rod, they're less commonly used due to inability to contour. As I mentioned earlier, the titanium rods are used often as they hit like a biomechanical sweet spot closest to the cortical bone, and it's more flexible than cobalt, reduces stress shielding, and also produces less imaging artifact on advanced imaging like CT, MRI. Cobalt chrome, it's great for maintaining the alignment and the correction of alignment. A little more difficult to work with as it's more stiff. And then PEEK has a modulus that's closest to bone, but it's not flexible, doesn't perform well with benders. The PEEK rods have essentially the best MRI compatibility without artifact. Titanium has minimal MRI artifact, and then the cobalt chrome further, and then titanium even more. And so depending on if you need to survey patients with MRI postoperatively, this may play a factor in what type of material you choose to do surgery with. And so intraoperative rod bending, it's essential to surgery, spine surgery, in terms of fusion and fixation. And what's important to understand that when you bend these rods, they introduce notches which act as stress risers. This can reduce the fatigue strength of the rod and increase the likelihood of rod fracture down the line. Biomechanical study compared notch versus notch-free rods made from titanium and cobalt chrome. The notch-free cobalt chrome demonstrated the highest load to failure strength, and essentially the takeaway here is that pre-contoured or potentially patient-specific rods may preserve the strength and reduce failure risk of these rods. The graph there shows that the notched titanium and cobalt chrome significantly reduces their ultimate load. So moving on to pedicle screws, it's a staple of spine instrumentation. Their design allows for transmission of force across the vertebral column and provides segmental stability. Majority of screws that are used today are titanium alloy due to the favorable biocompatibility and Young's modulus. Key biomechanical variables include bone quality, the screw length, the diameter, as well as adjuncts like surface coating or cement augmentation. Screw loosening and pull-out remain challenges, particularly in patients with osteoporotic bone, and enhancements in screw thread design, surface treatments, and trajectory planning help. Cement augmentation, coating such as hydroxyapatite, plasma spray can increase the strength of pull-out. This is a study, cadaveric study, that looked at screw depth and how it affected the strength of pull-out of these screws. They used chance screws at depths of 50, 80, and 100% of the pedicle length. And results confirmed what many of us would intuitively believe, that deeper screws provide stronger fixation. So at 100% depth, the screws had up to about 150% of greater pull-out strength compared to 80% depth. And so this translated to about every 5 millimeter increase in length added about 26% in strength. And so you should maximize the length of screw whenever possible within the anatomic constraints of pedicles and vertebral bodies. So this is a prospective randomized study of 80 patients evaluating constructs with and without inclusion of a fracture level within thoracolumbar fractures. Instrumenting the fracture level resulted in 6% improvement in kyphosis correction and significantly less construct failure, particularly the short segment constructs, one level up and one level down, in patients with unstable burst fractures. This highlights the importance of strategic placement and biomechanical outcomes. A finite elements model reinforced these clinical findings, including screw at the fracture level, improving stiffness in short constructs. But when the constructs are already long, the benefit is negligible. So for short constructs, isolated burst fracture with going one level up and down, if you can, it's important to include the injured level. Moving on to cement augmentation in osteoporotic spines, this can significantly enhance the screw fixation. This was validated by multiple biomechanical studies showing increase in insertion and extraction torque, and then they didn't see any catastrophic failure on the removal, which could be a concern. And so further stating that they were able to extract these screws safely, and they had higher torque resistance when doing so. And so this provides some confidence in the augmentations with cement. This is a retrospective study of 241 patients. It showed screw loosening was reduced from 50% in augmented group, unaugmented group, to 7% in the augmented group. Cement leakage occurred, but were not symptomatic. The fenestrated screws had a slightly higher screw fracture rate at 5% to none of the solid screw group. While both types of augmentation, fenestrated versus solid screw augmentation, improved purchase, the risk of screw fracture and fenestrated screws have to be considered, and then solid screws, if you're trying to put cement and then quickly put a solid screw down, it seems more durable from the study, but it's technically much more challenging due to cement curing and being able to put that screw down quickly. Moving on to surface treatments of these pedicle screws. This is a study that used pigs comparing smooth to sandblasted and acid etched screws. The acid etched screws had the best overall performance, higher pull-out strength and torque, better histology, and improved bone implant integration. The smooth and sandblasted showed some gaps on micro CT, indicating that they had some less contact with the bone. And so surface treatments can also provide advantages in implant anchorage and osseointegration. Titanium screws with nanoporous surfaces. A study they looked at nanoporous structures at 20, 30, and 50 nanometer pores, and they studied this in rat tibias. These microfeatures promoted early osteoblastic differentiation and improved bonding with bone. The nanoengineering of implant surfaces offer a powerful way to influence the cell and osteoblast behavior and accelerate the healing. In a human study, hydroxyapatite coated screws, significantly greater insertion and extraction torque compared to uncoated screws. These were removed at between 10 to 22 months and showed higher bony integration. However, they are significantly harder to remove and can provide some challenges when doing revision surgery. This is plasma immersion ion implantation, modifying the surface of polyether either ketone or PEEK without altering the mechanical structure of PEEK. This is in rat models. These treated cages showed greater bone mineralization at 2 weeks and better histology. Demonstrates the value of biologically active surfaces, and especially on bioinert materials such as PEEK. It improved the bone response after they modified the surface. Moving on to interbody cages. These cages provide significant purposes such as restoring disc height, maintaining the frame and patency, stabilizing the motion segment, facilitating fusion across the anterior column. The material and design can largely affect how the cage or spacer achieves these goals. Historically, rigid structural allografts were widely used, including femoral cortical ring grafts. They provided stability, but had some issues with graft resorption, as well as autografts, donor site mobility, as well as subsidence. These drawbacks led to exploration of synthetic material and for consistency and looking into the biointegration. A UCSF retrospective review compared peak cages to structural allograft in ACDF with greater than 2-year follow-up, 168 patients, 61 with peak and 107 allograft. There was no statistically significant differences in fusion, reabsorption, and or subsidence. However, peak was favored for imaging clarity and implant consistency, despite the limited osseointegration. So some biomechanical studies evaluated how the cage material, their footprint size, and substrate density affect the subsidence. In low density bone, the smaller cages had significantly more subsidence. This reinforces the value of the footprint and the contact area between the cage and the end plates, especially in osteoporotic patients. And the material type mattered more in poor bone conditions. So peak and titanium both showed higher subsidence rates in low density models. The rough textured cages performed a bit better. However, when you have normal or high quality bone, the effect of the material and texture were less pronounced. And so this kind of illustrates how patient-specific factors and their bone quality play a very significant role in the type of material that you decide to use for the cage. So the autograft, bone cortical autograft, had remained the gold standards in terms of biology, but as we talked earlier, drawbacks of donor site mobility. Allograft avoids the harvest issue, but it can resorb. Synthetic cages like peak and titanium are very consistent and allow for customization of the design. However, they, as well as like advantages of coating or hybrid types of cages to increase the goals that we're trying to get out of the anterior cages. However, a higher cost. So titanium cages promote osseointegration, are more stiff than bone, which can lead to subsidence and stress shielding. They also produce imaging artifact shapes and surface features like porosity can mitigate some of these issues, and 3D printing allows for greater customization of these implants. Peak, it's radiolucent, has a modulus closest to cortical bone. Reduced imaging artifacts, reduced subsidence, reduced, however, tends to form a fibrous interface rather than integrating directly with the bone. And so this raises further concern about pseudoarthrosis or migration of this cage and fracture of the implant since it's weaker. Titanium coated peak aims to blend the two pros of both peak and titanium. The imaging clarity of peak with the osseointegration of titanium. There's still concerns about this as the laminated surface can delaminate, potentially causing wear debris. And then 3D printed titanium and hybrid constructs attempt to solve these issues by further modifying like the internal lattice of the spacer as well as the surface. Early biomechanical biomechanical development studies showed that roughening or porous titanium surfaces led to better bone response compared to smooth ones, like we mentioned earlier. This was confirmed in vitro as well as early 3D design cages, reinforcing the importance of surface topography and the porosity of these implants that we use. This study looking at grit blasted titanium surfaces in rabbits, the grit blasting surfaces had higher integration. Looking at this article from Spine in 2018, they compared 20 different sheep with the cages places at L23 and 345. Looked at peak, the plasma sprayed titanium coated peak as 3D titanium alloy. They assessed fusion at 6 and 16 week or 8 and 16 weeks with the range of motion, the CT, histologic sections, and the density and volume of bone. They found no significant differences in range of motion, flexion, extension, lateral bending between the two groups at 16 weeks. They found that the in-growth and on-growth of the 3D cage was superior to the peak width, which theoretically leads to more stability. As mentioned earlier, they all had fibrous tissue surrounding it, but the peak had more than the two others, the coated and the 3D titanium. Looking at titanium coated peak sheep model, demonstrated significantly more bone in the micro CT qualitative rating when compared to peak, and histology showed newly formed woven bone tracking into the surfaces between. So the porous peak is newer to the market. Animal studies have shown greater incorporation of these porous structures compared to the smooth, having greater pull-out strength. More. So moving on to cervical disc replacements. The goals of cervical disc replacement include motion preservation, reducing adjacent segment disease, maintaining the sagittal alignment. The implants have to balance the biomechanics and biology, imaging clarity. The first modern disc was developed very early, FDA approved in 2007. It included a stainless steel ball socket design and plate secured by screws. And then the most recent iteration of this one is the Prestige LP. And they included titanium ceramic composites along with coating to improve the ingrowth of it. And so disc replacements, categorized by how many pieces they're made out of. The 3-piece discs are Simplify, Mobi-C, and Secure-C. They essentially, due to the 3-part design, allow for more motion. The 2-piece options offer stability with a fixed core, and then the choice can be dependent on your clinical goals and the anatomic factors. A list of the two component discs, and then a list of non-articulate discs, Bryan disc, and M6C, CP, ESP disc, right?
6 doesn't no longer exist.
Okay, some of these don't exist. I need to delete it. And then a little bit on lumbar arthroplasty. It was developed in the 1950, and that first um, attempt at arthroplasty in the lumbar spine is this steel ball and
Merchant ball.
try to replace the nucleus pulposus, but you can imagine probably did not do.
They actually worked pretty well.
They actually pretty well. Oh yeah, never mind. I assumed that they didn't.
Surprising.
Yeah.
Yeah.
Um,
I think Dr. A, who may not be on,
yeah.
remembers those, but you know,
Yeah. Yeah.
obviously long term they struggled, but they actually did
Initially.
reasonably well initially.
Oh wow.
Surprisingly.
That's crazy to think about.
It's like a ball bearing in your spine.
Yeah. So the earlier designs were metal on metal, and then around the same time, like the joints arthroplasty literature showing like metal on metal probably not a good idea with the pseudotumors and metal debris. But I don't know if that was ever figured out within the spine literature. I don't think it was.
They still use metal on metal.
Yeah. All right, and so two examples of these lumbar disc arthroplasties, Proteus scale and the Maverick. Yes, it's metal. And so in summary, the implant performance and the types of implant and metal alloys that we decided to use, heavily influenced by the modulus of elasticity, the osteointegration, potential ingrowth, on-growth, the radiographic clarity, and then the clinical factors of your patient. And so we have to really think about all these options and what would be best for treating our patients and the goals of our operations. And so that's it. Happy to.
Is that your last slide?
Yeah.
Oh, I thought you didn't have a summary slide.
No.
Oh, okay.
I just.
You didn't need one. I just
Yeah.
I thought maybe you'd
Yeah.
advance.
Yeah. Yeah.
Couple. The most important take home, I think, should be you just got to think a lot about every choice you make. And the science is moving rapidly, so it's hard to keep up with it, but you got to do it. And you have to question everything, like the fenestrated screw thing. How often have you seen a screw fracture at the distal third in clinical practice?
Like,
never.
I've seen zero.
Yeah. No, zero. It never fractures there because it's not where it's really stressed or where the bone is going to stress it, right? Because you got cancels, but where are the fenestrations?
Where is it?
Where are the fenestrations?
Distally.
Distal third.
Yeah.
So if you're worried about screw strength based on that study,
then you should put a solid one in.
No, you shouldn't be.
Oh,
so it's not a material concern.
Yeah. Well, clinically, it doesn't matter.
That's right.
Yeah. So, yeah.
It's something you should always think about. Okay, fenestrated means weakening, stress risers. Practically, does it matter? Probably not.
Mm-hmm.
Right. So that's an important consideration. What about the inert thing, bioinert? You said peak was bioinert. Is that true?
I think so.
Did it create a macrophagic response?
Yeah. So it's
not bioinert.
Yeah.
And topography and chemistry are different,
and
both have some positive or negative influence on the bioactivity, right?
Mm-hmm.
You take a bio non-inert substance like a peak, change its topography, and influence the bioactivity a bit in the positive direction.
Yeah, like the porosity or like the rigid, like the surface topography.
So bioactivity's got multiple inputs. And I don't know that there's a right answer yet as to what the coup de grace is.
Yeah.
The porosity, the topography, and the chemistry are all important modulators. Structurally, the modulus thing also is, you have to sort of sift through that. It's not as simple as modulus elasticity.
Yeah.
How do you reconcile the fact that trabecular bone is different than cortical bone in the last modulus.
Yeah, like I don't know which one to go off of.
Well,
Yeah.
no, but why? How did they come up with different numbers, given that it's the same substance? What's the difference?
Structure.
Exactly. So you could take the material, even though at its basis, stainless steel's got a high modulus, but if you change that to filamentous or some other structure, it changes relative stiffness.
For sure.
And so you can modulate its actual behavior in a way that's not reflected on that.
Yeah, these
sort of purity of modulus.
Yeah. These numbers are just like the pure alloy numbers. And,
right.
Yeah. A lot to think about.
Yeah.
Do you find anything in your literature search about whether if HA is incorporated into the PEEK or titanium as opposed to coated? Is there any difference in how they perform?
I didn't look at or see that question specifically.
I wouldn't think so.
Yeah.
It's done. I can't imagine it would unless you have a porous surface. You know what I mean? I mean, deep pores.
It seems like some companies are now selling HA infused titanium and PEEK as opposed to coated ones. So just wondering if there was any difference in the outcome ultimately.
Yeah, I mean, well, there's two different considerations. What's the basic science differential? And what's the clinical practical implication?
Yeah.
If you have the laminating where it comes off,
Yeah,
right?
that's a problem.
That's a problem, right?
Yeah.
It's a basic science problem.
Yeah. I try to look at the osteocentric screw design studies, but I couldn't really find anything that really showed like a biomechanical like comparative study. But that's another thing that goes back to structure and like the design of the screw.
Right.
We had used it for some of our osteoporotic patients.
Yeah, we might try to do some studies on it.
Yeah.
I think it's warranted.
Yeah.
There's nothing in the trauma literature yet.
It was a pretty brief like search into it, but I was trying to look at the specific design and I didn't really see anything come up. Yeah.
Yeah. Well, you'll see a lot more. I think with the custom stuff, the trabecular PEEK is now out there.
Yeah.
It's a mimics bone structure, and Kevin's point is fully infused. So deep into the structure, it also has the chemical properties that influence bone rather than just at the surface level.
Mm-hmm.
You know,
Yeah.
there's still this question of is it enough to have appositional growth for long-term stability?
Yeah.
Do you need through growth?
Yeah.
You know, we've wrestled with that.
Yeah.
But probably if you can do it at a reasonable cost, you can get it to be through, around, on, all of the above. That's probably the right answer.
Yeah. Yeah. Mm-hmm. Cool.
All right. Any other questions?
Did you mention carbon fiber screws? Have you guys anybody use carbon fiber screws?
We have them for tumor.
Yeah.
There's a couple brands. One's just specifically for tumor. There's another one, Ecotech maybe, that's got FDA clearance for infection utilization too.
Infection?
Yeah.
Is it personal bitter?
Yeah.
In titanium?
Yeah.
Yeah.
Interesting.
So if there's a cost that's keeping us from using them a lot, right? Because there's
they're much more expensive, right? So, they're not to use them unless you really need them. If you have to, the advantage, of course, is you can image with MR after the fact and not have this artifact.
It's a huge advantage because sometimes the screws just look so funky.
Yeah.
So,
And to be fair, I'm not sure if there's actually an infection treatment advantage with the screws, you know what I mean? Glycocalyx, these differential stuff like that. The infection is they're more resistant to infection, colonization. But
so if it was for the cost, would you use a lot more of it?
probably not, because they're not as nimble either. I mean, there's rods, for instance, you can't bend and form the way you want. So There's some, it's like a rudimentary system that's okay to get through, a reconstruction that you really need to see post-op imaging, but you wouldn't choose to use it for bread and butter and
I see.
more complex recons.
So it's probably still like first generation.
Yeah, exactly. And there may always, because of the material, there may always be limitations
Yeah,
in what you can actually modulate in it when you're doing instructions.
I see.
Ready? Switch over?
Yeah.
Let's do it.